So this is what episode? Episode three?
Three.
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 Welcome
Welcome
back.
back.
You made it this far, people. You're on episode number 3 of Too Much Plaque to Handle. And today we're talking all about diagnosing periodontal disease. We're going to go into depth of staging and grading, radiograph assessments, risk assessments, and we're also going to talk about just the basic treatment options that we can cover. We will get further into depth with those treatment later in later episodes. So I guess we're gonna kick everything off by starting with just diagnosing. You, Cheyenne, as a hygienist, I know you guys aren't legally supposed to diagnose. Legally, which I think
Legally.
is kind of bullshit if you ask me.
I think certain states, there's like a small handful of states where hygienists can, and it's more so the ones where you can own your own practice can.
Mm.
But in my state, you can't. Hopefully that will get expanded. We're kind of fighting for hygiene expansion in my state, but we shall see. I've been lucky though. Most dentists that I've worked with really have taken kind of my lead on that sort of thing. If I have a patient, because I'm doing the whole perio chart, if I have a patient that I'm like, they really need perio treatment, 9 times out of 10, the dentists that I've worked for throughout my career have really like backed me up on that, fortunately.
Do you think there's a difference between how I diagnose as a periodontist and how you diagnose as a hygienist?
I would think baseline diagnosis would be the same because we both do complete perio charting, like with all the extra odds and ends. Like I do the mobility, furcation, recession, all of that stuff, FMX, pan. So I think the baseline is pretty similar. Staging and grading, going by like that same chart from the Academy of Periodontology. I think where it then differs is up until really we met, I've not ever talked to a periodontist this in depth to know what actually happens when the patient gets to you. Like I refer them out into the
Yeah.
void and I'm like, bye, see you later when you're stable. And I mean, I know that like bone grafts and like flaps happen, but I just never really understood who qualifies for what surgical treatments and
That's fair.
why. So I think you have that perspective of like you can perio chart someone and look at their x-rays and already be like, can they have Linap or not? Can they
Mm-hmm.
have this or not? Whereas I'm looking at it like, can I treat you or do I refer you?
It's like, which way are we going? That's, I mean, it's a really valid point because I think we do look at stuff a little bit differently because I have obviously a different perspective because my end goal is stability, the same as your end goal, but how we get there is going to be different because we just have different scopes and it's the difference between periodontist and a hygienist, but that's just how it is. But I never really thought of it that way in that you're really looking at it to diagnose, but you're also looking at it to when to refer. And I think I get a lot of these questions in my live from hygienists saying, when do you want me to refer? When should we refer to a periodontist? And I want to know what you think before I say what I think from a periodontist perspective. When do you refer? What's your cutoff? What are you looking for that referral?
For me, okay, I'm going to think of me when I was a baby hygienist because now, especially working in such a rural area where perio is a much higher percentage of the population than maybe in a more like a city with more access to care. When I was probably a pretty new grad, probably up to my first couple of years, I was seeing hard cases, but anything that was above 6 millimeters, I immediately referred. If it hit 7, I was like, you're gone. I can't do this. The longer time went on, you build your skills a lot more out of school. And I just had all these patients that couldn't get to a periodontist. It's like they maybe wanted to go, but we don't have one in town. And they're like, older, they're lacking someone to take them. So I just kept kind of pushing myself a little further. I would take a little bit harder cases. So then I was like, okay, I'm good with 7s. If you hit 8, referring you. And then it just kept kind of like pushing a little bit. I'd say for me, it really depends like case to case because I've had some cases where it is 8, 9 plus millimeter pockets, and they have no way to get to any other care other than us. And I will try my absolute best to do everything I can. And that's why I've ordered all these crazy instruments nobody in general has heard of. But, if it were an ideal situation, if you're in a town where you have a periodontist and you have access to care, I probably would refer if it was a 7 and up. Just if you don't have the instruments to be able to do the best you can. If you know without a doubt that you're leaving stuff way down under there and your instrument doesn't go beyond 5 millimeters, because I have instruments now that go beyond 5 millimeters. If you don't have that, I wouldn't be trying it to then just turn around and refer and the patient have to repeat the same treatment, if that makes sense.
Like repeat the SRPs. Where you going with? Which
Yeah,
happens. I mean, that does happen. Get referrals from student clinic all the time that I'm redoing SRPs, but the student clinic's also the student clinic.
right.
They're still learning, so obviously we know they're not gonna be perfect, they're not gonna get everything. 9 times out of 10 when it comes from a student, I'm like, we're probably redoing these SRPs to start with."
Yeah.
But,
I
I mean,
think on the side of, like, private practice or, like, just being in the, like, quote, unquote, "real world," I try to do as much as I can to avoid patients having to repeat it if it's, like, that situation where I'm like, "You definitely, like, one regardless of what I do, you're going to have to go to a periodontist, so I would rather just send you to them and let them do everything for your case, like start to finish, than for me to start it already knowing that I'm sending you anyways, just
yeah.
to kind of save them like the time of all the appointments and like having to repeat stuff because then they're going to have to come to us to do 2 2-hour appointments and then go to a periodontist and do more of the SRP.
But we always start with non-surgical treatment, so that's what we call it. I don't know if you've heard it called that
Mhm.
before in school, non-surgical treatment, yeah.
Yeah,
Scaling and
that's what we
regrading. Is
called it
that what you
in
called it too?
hygiene. In school, we called it that.
Yeah, we actually have a full lit session every semester dedicated to reading literature. Usually, it's more of our classic lit back in the some of them are 60s, 50s, like our classic lit, like that established this specialty in perio and really talks about the advantages of non-surgical treatment prior to any surgical treatment because that non-surgical treatment helps really decrease bacterial load. It helps reduce inflammation and edema in the tissue, which is can be detrimental to surgery because the tissue's not going to handle the same. I'm not going to get a clean cut out of a very inflamed tissue. I'm not going to get good clean closure and clean sutures. And so the healing process for patients is going to be a lot better too after a good initial treatment, and that can be done with a hygienist, and I think there's a lot of hygienists, like you said, that can they see those deep numbers and they kinda run scared, but it's like, if they have 8s, we're going to surgery. We
Mhm.
need to. There's no way we can maintain that with just a cleaning. I mean, we can try and have them on a compromised maintenance, but if it's an 8 millimeter probing depth with bleeding and I can see there's noticeable infection, we're doing some sort of I'm thinking in my head, okay, we're doing some sort of surgical treatment at this point. At least that's the next step after your initial non-surgical. So I think the way I diagnose is a little bit different in that regards. Obviously, we stage and grade too, like, World Workshop, the AAP recommendations of staging and grading of active periodontal disease. But I'm also looking at what those next steps are of like my diagnosis is also going to help really dictate my treatment plan. Because when I'm looking for verticals that I can graft. I'm looking for horizontal bone loss that maybe needs osseous recontouring with negative architecture. I'm looking at all the soft tissue, not just the recession defects, but how much thickness of KT do we have? What's the width of KT do we have? Keratinized tissue, for everybody who's listening doesn't know what KT is. Keratinized tissue is the thick tissue that goes around your teeth. Then you have your mucogingival junction where your KT moves into your mucosa, which is that softer, more friable tissue. A lot of people don't have enough KT around certain teeth, and that can play a big role in periodontal disease because now you don't have the soft tissue attachment that you should around each tooth that those fibers of connective tissue in the KT help seal the tooth from bacteria. And so Usually patients that have periodontal disease, those areas that have no KT actually have a higher probing depth. It's more exacerbated in
Mhm.
those areas. So when I'm diagnosing, I'm looking at those areas and what exactly is going on in those deep areas and what we need to do to stabilize it and to not necessarily fix it per se, because periodontal disease, obviously we can't reverse it, but we can stabilize it. We can keep it from progressing. So what can I do to keep it from progressing and make it maintainable for the patient to keep clean at home? Because that's the ultimate goal, is to be able to maintain it and the patient be able to maintain it and keep up with it. Because if they can't keep up with it, then I can do surgery all day long and it's not going to do anything. It's going to continue to progress unless the patients are actually able to maintain it. So that's what I think about when I'm diagnosing and I'm going through all the charting. Is I'm also looking at, RT2, Cairo, RT1, RT2, RT3 recessions, Miller recession defects. There's lots of classifications, Sullivan and Atkins. Is it narrow, deep? Is it narrow, shallow? So it's like there's a lot of other classifications that I use to diagnose. The gingival phenotype I use to diagnose. Like, is it a thin scallop? Is it a thick flat? Or is it a thick
Mm.
scallop? There's three different types. So it's, for me, our diagnosis goes way beyond just the staging and grading. It's a
Mhm.
lot more to it for our diagnosis anyway.
Right.
Do you do any
Yeah.
of that?
Especially if you're going like surgical and you know you're going surgical, I feel like y'all have so much more. Y'all have to like document and show your findings on. We do, which I'll say, I do have pretty thorough notes for hygiene. Every office I've ever worked at, I use my own note template because I put more than what offices generally have as their like template. So I'll put not like classifications of the tissue, but defects I do put. And when I do stage and grade, if they have modifiers, like a lot of people will just put stage 3 grade C and just leave it at that. Whatever the modifiers are that are making them jump to those stages, I list all of those. So say they're stage 4, class 3 mobility. Um, or grade C, their diabetic A1C is above 7,
Through the roof.
or they're a smoker. And so I will list as many details as I can, but I will say ours is much, not that it's not in detail, but it is not as far as y'all go on the side of perio specific.
Yeah, and you learned in dental school, in hygiene school, the old diagnosing, right? Like the moderate, severe, mild, moderate,
Localized,
severe, right?
generalized. They started hygiene school in 2017 and they came out with the guidelines in 2017.
Okay.
But boards are always behind the current literature. So we had to know the old way for boards, but we had to know the new way for practice. And so it was kind of like you're stuck in this place, like where you're looking at your instructors, like, which way do you want me to tell you that they are? Because they're a stage whatever, or they're moderate, severe, generalized. So like, what do you
What do you
want
want?
from me? So it was an interesting time to be in school when that actually changed because hygiene goes more like in depth, I think, with that than dental school, but then perio residency and like working as a periodontist goes more in depth than hygiene school.
Mhm.
So it all kind of like layers.
Yeah. So you learned juvenile periodontitis as a
Hmm.
diagnosis.
Yep.
How do you feel about the World Workshop taking juvenile periodontitis out? And they made it the molar incisor pattern, but they didn't necessarily classify it as juvenile periodontitis. They combined them to make it seem that juvenile periodontitis is in fact a subset of regular periodontitis.
Feel like it's tricky. It's tricky because in a perfect world, could that work? Yes. But in a world where insurance companies run it, I think it's going to be a lot of denials. Already, insurance companies deny SRP if you're below a certain age because it's like as if they don't think juvenile periodontitis exists. So then if you take that and you have this group saying, "Oh, it's not juvenile periodontitis that we've been fighting for insurance companies to understand," and you say, "Oh, it's not this. It's, we're going to reclassify it this other way." And who knows, maybe they're thinking that it will help people actually agree and understand it, but I feel like they should have left it alone.
I agree that I think they should have kept juvenile periodontitis separate because they're different pathogens. We
And it's more
know that
aggressive.
aggressive, yeah, we know that AA, actinomycin aggrecan something
Here we go.
AA is the main culprit of juvenile periodontitis, and that's not the case for adult periodontitis, and
Yeah,
so they are not the same disease. They're not treated the same. They're treated differently because of the aggressive nature of juvenile periodontitis, and the fact that they combined the 2 diseases, making it seem like they are the same, they're not. So I
they're
think
not.
that that was kind of a big oversight on the committee, and I feel like even now, like, to this day, we're still talking about it. Even in our residency, we're talking about it, and our director is like, "Well, what do you think? Do you think it should be separate? Do you think it should be the same?" And I was like, "I think it should be separate. They're different pathogens. They come from different places. They're treated differently. I'm gonna treat a juvenile periodontitis case a lot more aggressively than I would treat an adult periodontitis case, right?"
Probably the first time I ever saw a juvenile perio case, I mean, it floored me, floored me,
Aggressive.
because in my head, which by this point, I think at the point I saw a juvenile perio case, I'd probably been practicing for like 2 years because it's not super crazy often that I'm gonna see it. I see perio constantly, but it's just like on the side of kids. I hadn't seen it very often. But the time I did, I mean, I'm like, "Oh my god," because I'm sitting here like, this is worse than all of the adult perio cases I'd seen by that point. And I'd seen some crazy cases. And so it's like you're looking at this almost disconnected when you're looking through like high magnified loops into somebody's mouth. It's like you just see the mouth and then reality hits and you're like, this is a child.
Yeah.
This is a child. And I think people look at so many other systemic diseases of children and take it so serious. They're like, "Oh, you're diabetic. As a child, this affects you the rest of your life. It's really dangerous. Childhood obesity can really affect you for the rest of your life." No one ever looks at what's happening in a child's mouth to affect the rest of their life.
Nope.
And it does. And it's so aggressive. It is so much more aggressive than the adult patients that I've ever seen with perio.
It deteriorates the bone so fast, and it is that textbook, the molar incisor pattern presentation, and, I mean, I've seen it where I've treated a few juvenile cases that were severe. Obviously, they're coming to me. They're sent here because a hygienist took one look at them and went, "I can't treat this." Yeah, and,
I mean,
like
it's kind of like it's almost terrifying, especially like if you work in general dentistry, you're gonna eventually see some pretty rough perio cases that 9 times out of 10 are gonna be immediate referrals.
Mhm.
But the first time you see a child and it's that bad, I mean, it just like flips your whole reality of health and perio and how perio works and functions to do that type of destruction.
That
And
fast.
and I've only seen it on maybe 3 juvenile perio cases, and all of them, it was, like, different locations, but all of them was the most severe, like, deepest probing depths I've ever seen, the most mobility you could ever see, and it's just crazy that nobody thinks anything of it until it's, I'm guessing, their child, but the world doesn't think anything of it.
Yeah, it's pretty hard, and it's hard to have that conversation with the child and their parent and tell them, "You're probably gonna lose these teeth because this should have been caught a long time ago, and now it's progressed to the point where I can't fix this." And what does that do to a child's self-esteem when they lose teeth at such a young age? Not only that, but what does it do to the development of their bone? Because your bone needs your teeth to develop and grow as they age, And if they lose those permanent teeth prematurely, it can be detrimental to the growth of the bone, of those facial bones. And I mean, I know that firsthand from my story and losing my teeth prematurely, and that bone did stunt its growth. And it's hard, and it's hard to have those conversations because, I mean, how do you tell a child they're gonna lose their teeth?
Right.
I think that kinda sucks for me because I'm the one that has to do it. A hygienist won't. A hygienist will be like, "I'm gonna refer you." And then they come to me and I go, "Oh, fuck." Now we have to
Now,
have a
I've had
really hard conversation.
a lot of times I try to, quote unquote, they say to like preheat the patient for the doctor. Yeah. So like say that somebody like we know looking, you're gonna end up losing teeth. It's almost like they want you to kind of tiptoe them into that. Like, hey, I can't say for sure, but the prognosis of this is unstable. I'm not sure what the doctor will for sure say, but the outcome, there's not really a good long-term outcome here to kind of get in their head so that when the doctor comes in, they're not just like gut punching the patient with their
Mhm,
diagnosis. But at the same time, I've done that with adult patients, like, say a tooth is broken, like, unrestorable, and I'm like, "Hey, 9 times out of 10, our doctor says when your tooth is beyond 50%, restorative materials and it's fractured, 9 times out of 10, they're going to recommend a crown, but we'll see what he says."
mhm,
And then when he comes in and 10 times out of 10, they recommend the same thing I already said.
mhm.
But it's like to kinda just, like, get the patient in that mindset. I never do that with kids, though. I never do that with kids.
Can't.
I can't. I can't because I feel like that'll be the time that either it's even worse and they're like, "Well, why didn't you tell me? Like, why did you make it sound this way or that?" Especially, like, it's a rocky kinda situation with the kid doesn't understand in general. The parent, unless the parent works in dentistry, doesn't understand either. I mean, we're gonna explain it to you, but it's not like you're truly understanding it the way we do. So I don't want two confused people mad at me because I either made it sound better or worse than what the doctor then comes and says. So when it is kids, yeah, I'm gonna refer that to you, Hannah.
It's fair, which is what happens most of the time, like I said, that happens. I I've had to learn how to handle those situations. Half of what I do in residency is learning the procedures. The other half is learning patient management and how to manage those hard cases, have those conversations of we're gonna have to do surgery or we're gonna have to take out teeth or learning how to proceed with caution. But one of my attendings, he always says as conservative as possible, as aggressive as necessary. And I
Mm,
think that's a really good philosophy to live by
I like that.
with our surgeries is because we try to make our incision as conservative as possible because that's going to heal better. However, I'm going to be as aggressive as necessary to be able to get the outcome that we need with the procedures that we do. And there's some people that don't necessarily abide by that. And I think that's a really good philosophy. And I think that's something that he's taught us and I will definitely use for the rest of my career.
Yeah, I do like that, the way
Yeah.
that is stated, because I'll say in the realm of general dentistry, I feel like you see it on like hygiene pages or dental natos or just these different groups, and you see it in real life. It's like either people are super aggressive with their treatment planning or they're way too conservative,
Yes.
and there needs to be that middle ground.
Yes. 100% agree. Yeah. So I see both ends where they've been way too conservative and now they're coming to me trying to fix it. And I'm like, I can't fix it. You should have sent it to me years ago. I definitely do see that a lot where they're not diagnosing aggressively enough and something should have been done way sooner. And then there's the other end of the spectrum with people who are diagnosing too aggressively. Well, not necessarily diagnosing, but they're treating too aggressively. So a diagnosis and a treatment plan are different. A treatment plan is the philosophy of the provider who's been through the training to develop their own treatment planning philosophy. Even though you have the same diagnosis, there's different treatment for that same diagnosis. And some people's philosophy with treatment planning can be too aggressive, in my opinion, because there's now this new era of like all on X cases, which are implant fixed prosthetics that people are taking out perfectly savable teeth. They might not be perfect teeth, but perfectly savable teeth, and placing a bunch of implants for these beautiful prosthetics. Don't get me wrong, they look great, but now they're failing because patients aren't taking care of them like they should, or they think, hey, this is the best option. I don't need my regular teeth. And this was sold to me, and not I'm paying $60,000, which is a freaking car, in your mouth.
Mhm.
And I think that we're over treatment planning those cases. So it's like I see
Right.
both ends of the spectrum of people should have seen me a long time ago, and then you should have seen me a long time ago, like on both ends.
Yeah. With perio because the majority of your perio treatment planning starts with perio. How do you explain perio to your patients? Like,
That's
do
a
you
really good
tell
question.
them, like, tell
Tell
them what
them.
it is or like what the numbers mean before?
I tell them what I'm going to do. I don't tell them what the numbers mean before, because I don't want them to hear numbers and start freaking out.
Right.
Because I've had patients do that. I tell them I'm going to take measurements of your gum tissue, because it's literally the probe is, I'll literally show them. I'm like, it's a little ruler. It's like it's millimeter increments and millimeter increments. And I tell them I'm measuring your gum tissue around each tooth. And this is going to indicate to me whether your gum tissue is healthy or if we need to do some treatment. And usually the patient already knows that something is going on because they're coming to see me, and so they've kind of been told ahead of time, hey, I think we need you to go see a specialist. They're a little bit more well versed with these more complex cases or more medically complex cases. So it's just, I try to tell them, like, I'm going to measure your tissue. I'm going to be calling out a bunch of numbers, and those numbers are going to tell me what I need to do next. That's how I explain it to patients. And I always tell them if anything's uncomfortable, let me know, because I know, especially certain patients come in and there's very deep probing depths, this is going to be uncomfortable. And there's times
Right.
where I've had to numb patients for the probing depths.
Yeah, I do the same. I'll just tell them kind of like generalize what we're doing and that it is probably going to be on, like, if I've already looked at the X-rays and you can see calculus all over the X-rays, then I'm like, it's probably going to be uncomfortable. I can tell your gums are pretty inflamed, but I don't say the numbers either. I do hear a lot of other people will explain before what the numbers mean, like, oh, if it's above this, then we have some inflammation. If it's above this, we have disease. Bone loss is starting here. And I don't tell them before because I'd rather take everything and have an understanding for myself. Is it more generalized? Is it just localized? Kind of be treatment planning sort of in my head of what all they're probably going to need. And then once I set someone up, I have like all these visual guides of showing probing actually, and it's like a little flip guide that has one side everything stays healthy and the same, and the other side it's like 5 millimeters, 6 millimeters, and it shows the bone going down.
Oh, I
So
have something similar. It's not as
I, s-
cool as that though.
I use it all the time, and so I show people that I show people their perio chart, and I'll like point out the different measurements. I'll be like, oh, you have a 7 here, and I'll flip it and be like, this is the 7 compared to what it should be, and then show them their x-rays and be like, oh, and in this area, this little fern is calculus. And it's like having a splinter down in your gums.
The low wingy.
Yeah.
That's a
Yeah.
good, that's good. Visualizations are always good.
Yeah. I go super. I feel like sometimes I do too much, but I am of the philosophy I would rather have a patient leave knowing I did everything possible to help them understand what's going on than for them to leave and be like, "What the heck did they just tell me?"
Which I'm sure I have patients that leave like that too. I try to explain it as best I can, and I'll tell them, "Hey, do you have any questions? Does
Right.
that make sense what I'm telling you?" Because I try to say it in the most layman terms
Yeah.
possible. Because it's hard when you're talking to somebody who has no medical background and terminology. It's you can't tell them, "Oh, by the way, you have an 11 millimeter probing depth on the distal of 18 with a vertical bone defect, and I wanna do an allograft to be able to fix it," and they're like it's like the meme with the guy who's like oh, no, is it Julia Roberts where she's, like, thinking really hard and all, like, the math equations are, like, going
Yeah.
past that's what I picture my patients are when I'm trying to explain any of my surgeries that I do. They're just like, "What is she
Huh?
talking about?"
See, here in the South, I call that a deer in headlights.
It's about right.
I just stop,
Just
stare
stare.
at it.
Yeah, that sounds about
Uh,
right.
well, say, I know you said treatments in general, y'all always do start with non-surgical. We say NSPT, non-surgical
Yeah.
periotherapy. And then I do tell my patients when we go to SRP, like after this, you're going to be on perio maintenance, and perio maintenance becomes your quote unquote normal.
Yes.
And I do tell people, I'm like, I'm not saying you'll never have to repeat SRP because I've seen a lot of patients have to repeat it
Yes.
because something happens, they get off track, home care's lax, just the life happens. And so I'll tell them everything to do with what perio maintenance is. We're doing this every 3 months, maybe 4 months is the most we're going to push it, but we'd prefer 3 months for the rest of your life.
How do you explain that to patients, the 3 months? How do you tell them this is why you have to come back every 3 months?
I tell them, so here's like my layman's terms explanation. I'm
Mhm.
like, the bacteria in your mouth, when we go in, we're destroying it essentially. The cell wall, we're like with water, the cavitron, we're like bursting the cell walls. We're destroying the bacteria below the gum line. You can get maybe 3 millimeters below your gum with flossing, maybe. Brushing's a little bit less, and a water pick might be a little bit more if you're using it right. So I'm like, we have to go down into those deeper areas to be able to get rid of that bacteria. So you're going to do your part at home, and then you're going to come in here every 3 months so that we can get the rest. Because it takes about 12 weeks, give or take, for that bacteria to reform almost like Legos, like it builds itself back up. Then it gets to a point where it can start affecting your bone again. And then we go in and we tear the Lego house down.
I like the analogy.
'Cause I'm like, it's not that every single day it is doing damage, like, from the second that you get up out of our chair, but it gets to a point where it is going to start doing damage again. So that's where you're gonna go home, you're gonna do all your stuff at home to get everything as deep as you can, but for those areas that you cannot maintain, we have to do that. So you're gonna have to come back regularly.
Regularly, because there's a lot of patients that'll be like, "Well, my insurance only will pay for 2 cleanings a year," and they're like, "Well, I don't wanna pay out of pocket." I mean, you have to tell them, "This is the reason why you have to come back, because this is how long it takes for the bacteria to recolonize, and if we go any longer than that, it's gonna revert back to pre-SRPs, and we're gonna start seeing a progression of the disease again. And I think there's a lot of providers that don't explain that well enough. They might explain it a little bit, but maybe they don't explain it enough so that, like you said, that the patient can actually understand it. And like we got to break it down for the patient to be able to understand why we're needing to do treatment. Otherwise, they're not going to want to do it. They don't understand the scope of what we do. Yeah, you have to explain it to the patient in very, very layman's terms and Lego analogies
Yeah.
to be able to
Well,
get them
you
to
see,
understand.
I build
That's
Legos,
great.
so it was like just the analogy that always stuck in my brain. Like it takes a long time to build a big Lego set.
I like it. I do. I'm going to use that. I think
So
I
I
need to use
just
more layman's terms, but that's a good analogy.
I try to incorporate both because I think, you know, the public doesn't understand what we do to the point that, like, I try to explain it that way and then maybe say, like, the bacteria recolonizes and we burst the cell wall, which kills it. So it's like I'll give them the layman's terms and kind of slip in some of the more medical terminology so that maybe throughout their lifetime, they're kind of understanding that this isn't just a Lego house. It isn't like that simple. It isn't just super easy to keep it under control and treat it, and have to repeat that every time. So I try to tell them, or like when I talk about bacteria in the mouth, I'm like, bacteria in the mouth really hates water, and I'm using an instrument that is spraying water. And so then to say it's killing it by doing XYZ, or people just say cleanings, everything is a cleaning. So I'll say, today we're doing your perio maintenance, or today we're doing your scaling and root planing, which is what people call deep cleaning, quote unquote. But I try to give them both to try and make that connection because I think it elevates the importance for people when you understand that these are actually medical procedures. It's not just dilly-dallying under the gums a little bit.
No, that's a valid point. That is a very valid point, is keeping it to the point where they can understand it, but keeping it professional and in terms of our scope that the patient does understand, hey, this is a medical procedure. We are doing this because there are systemic ramifications of this disease that we have to treat. So we are trying to dumb it down per se so that they understand it, but we're also trying to keep the importance of it. Yeah. No, it's valid. It's very valid.
Where I'm at with it.
No, I like it. I like it a lot. And so when obviously in the first new patient appointment, a full comprehensive eval is important. You got to talk about their medical history, which plays a big role in their genetic susceptibility of periodontitis. Are they obese? Do they have other systemic conditions? Are they a smoker? Do they drink alcohol? Obviously, diabetes plays a big role as a risk factor, uncontrolled diabetes in particular, and then stress. And so, do you talk to your patients about all of those systemic factors as well? Like how much do you go into it with your patients?
I do, and it depends on their particular history, their medical and social history, as to which aspects of systemic, like oral systemic health I'm talking about. If they are pre-diabetic or diabetic, I talk to them about everything I can to say periodontal disease is active infection in your body. When you're diabetic, it is harder to fight infection, no matter where it is. You have a slower healing and a harder time fighting infection. So if you have a high bacterial load in the mouth and say you cut your foot, you may end up with more extreme medical complications with a tiny cut in your foot because the periodontal disease in your mouth is running rampant. And then on the flip side, I'll say, but also you're diabetic, so you have a harder time healing. So the periodontal disease in your mouth, in general, your body can't fight the calculus aspect of it or the biofilm because you manually have to remove that. But your body is almost flooding your mouth, all these white blood cells, and they're just sitting there. They can't do anything. So the disease runs more rampant because your body can't heal. When we do anything surgical or even non-surgical, you're going to have a slower healing time because of the diabetes. But if we don't do something about the disease in the mouth, it's going to continue to affect the whole rest of your body because of the diabetes. It's like it all goes in this
Oh yeah,
cycle.
it's a vicious cycle. Yeah.
So I talk to them a lot about that. It just depends on like what a person has. If someone has heart disease or they have a history of heart attack or stents, I talk to them about the link of perio to heart disease. Smokers is a big one. It's
Big one.
smoking in general. It causes everything, not everything, but it's a lot of issues. So, I talk about, with smoking causes higher risk of periodontal disease. And then once you have it, it lets it kind of run rampant. So I do talk as in depth about whatever the particular circumstance is, but I have had patients that say they don't have anything really marked on medical history that's an issue and they have pretty severe perio. I'll talk to them about like, perio's now been linked to Alzheimer's in later life and linked to different cancers and, try to get them to see that it's not just in your mouth.
Yes. And I think that's a really good point with smoking. And something that I think a lot of young hygienists and as periodontists need to consider, though, is that smoking can also hide periodontitis because
Because you don't bleed.
you don't bleed.
You don't
It
bleed.
constricts the blood vessels, so it can really hide how bad the disease is when you have a smoker, and it's something that I know that as you're an instructor, do you talk to your students about that and be like, "Hey, is if this patient's a smoker, you need to be very well aware that if they're deep probing depths, but they're really not bleeding, that's not accurate per se?"
Yes, yes, because they have to do a really thorough it's like they do a really thorough medical history, a really thorough almost like social history, so they have in there, like, drinking, smoking,
Yep.
everything like that.
Recreational drug use, all that.
Yep, caries risk, perio risk, oral health assessments. So they do a lot of upfront documentation and then they go in the mouth. So they kind of already have an idea in their head of they're a smoker, they smoke a pack a day, and smoking inhibits the bleeding. So we do go pretty in depth with all of that with
Good.
them.
That's awesome.
And I talk to patients about that because I'll be like, hey, you may not recognize that you have any issues when you're brushing and flossing because I ask people, do you notice any bleeding at
Mhm.
home? You may say no, you've never had any bleeding, but you're smoking a pack a day. And that is a vasoconstrictor, so you're not going to bleed or not bleed as heavily.
That's yeah. I feel like my smokers I'll still get some bleeding, but not like they should be. They should be
Hmm.
bleeding at, like, every single point, and
Yeah.
they're not. They're only bleeding in very select sites, and I'm like,
And the tissue looks different.
"Yes." It almost
Like it,
looks gray. Have you noticed that?
yeah. Yeah, I was
Chews
gonna
doesn't
say
have
it's
it.
like blanched.
Yeah, it's like
Yeah.
blanched. It's not like this
Yeah.
healthy pink gingiva. It's almost like a
It almost
it
looks like anemic. Like if you were anemic
yeah.
and you're like
Yeah.
pale, the
Pale.
tissue being pale, or like when people are like about to pass out, they say like if you
Mhm.
can't tell by the face, look at their gums. And so I'm
Yeah,
like,
for sure,
and
yeah.
so
There's
it,
no blood flow. So,
yeah,
there's no blood flow, so you don't have that same red, pink color to the gingiva and
mhm,
in the mucosa, and so it just looks pale and unhealthy. It really does. It looks so unhealthy for
it does.
smokers, and that's something I really try to talk to my patients about, especially if, like, I'm telling them, "Hey, we need to do surgery." I'm like, "You cannot smoke."
Yeah.
Like, we need to stop now. Like, I have a patient who wants to get on all on X, and she was smoking 2 packs a day. Yikes, right? We really don't wanna do any surgeries on patients that are smoking more than 10 cigarettes a day. 10 cigarettes is like our cutoff.
You have to have blood flow to heal.
Yes.
And
Yep.
people just are like, I'll be fine.
They're like, "Well, can you try it?" And I'm like, "No, I cannot. It doesn't work that way." So it's just like, you gotta have those conversations with those patients, and those can be hard conversations to have, but especially if a patient's really motivated and they're probably gonna lose a bunch of their teeth because a lot of those patients who are very heavy periodontitis, heavy smokers, most of the time, I probably wanna say 7 out of 10 of those cases, we're probably doing dentures,
Yeah.
unfortunately. When we got a lot of mobility and a lot of bone loss, it's I can't save that.
Yeah.
Yeah,
Well,
sucks.
when you do like really complex cases where you start with your non-surgical, then you go to your surgical options. Are there different like things you really look for where you're like, I see this and immediately know this person would be great for LNAP or this person would be great for like guided bone regeneration? Are there different things that you immediately see and know like what you're looking for surgical options?
Yeah, so there definitely are. So when we're doing bone regeneration, I need at least a 4 millimeter vertical bone defect to be able to regenerate that. So it's got to have enough of a defect to hold bone grafting. Otherwise, it doesn't really take.
So like 4 plus.
4 plus. Yeah. So at
Okay.
least like a minimum of 4 millimeters. So if we have less than 4 millimeters, that's when we're typically looking at osseous surgery, like typical perio osseous, where we do a flap and bone recontouring, maybe some gingivectomy, like a modified Windman flap, where you take a collar of tissue and do pocket reduction. So we're doing
Okay.
resective surgery instead of regenerative surgery. I prefer regenerative over resective if I can, because when you start doing resective surgery, that's when you start getting a lot of recession around the teeth, and a lot of patients don't like the aesthetics of that. So you have to be careful when you start talking about resective surgery. But that's where Linap comes in. Linap is a great alternative to osseous because it does have some regenerative capabilities in the smaller probing depths that maybe we couldn't typically traditionally bone graft. And maybe there's a patient that's more systemically compromised health wise that we don't want to do a full surgery, like huge flap on. So a more minimally invasive approach would be a lot better for that particular patient. That's when I would consider doing osseous. So has it completely, does Linap, which is the laser assisted new attachment, like periodontal attachment. It's a laser treatment with the ND-YAG laser. It is great, but it does not take the place of osseous because there's stuff that osseous can do that Linap does not. So osseous surgery with the recontouring of the bone, if you have really big bony ledges that are plaque traps and it makes it hard for the patient to keep clean, that we need to smooth, like exostosis, like bony exostosis, that's when you would lean towards osseous versus Linap is when you have stuff like that. And then if we do have big vertical defects, I've personally had very good success with just doing a traditional guided tissue regeneration, which is the bone graft, the bone regeneration, where we do a flap, typically trying to keep it as minimally invasive in that select isolated site, cleaning out all that granulation tissue, putting in bone material, typically with some biologics like GEM21, which is recombinant human platelet derived growth factor, PDGF. It was developed by Dr. Lynch back in the early 2000s, late 90s. He spent basically his whole life and he came up with this, and it helps with chemotaxis and actual cell recruitment, helping bring those cells to the site to help regenerate the bone in that area. And I am a really big GTR person. I've seen some great results with that. And to the point where we've had 100%. One of my cases is literally over 100% bone
Mm,
mineral. We actually regenerated probably an additional 2 millimeters, which is like unheard of. I don't know how we did it, but we did.
that's
So
really cool though.
it is
Now,
really cool.
is that where you draw blood? You draw the patient's own blood and you
That's
like,
PRF. Yes. So
okay,
that's
okay.
PRF. So that's the platelet rich fibrin, which you draw the patient's blood and you spin it down and you centrifuge it to be able to pull out a specific part of the blood with all the growth factors. Gem 21 is a prepackaged, so it's actually made in a lab. It's synthetic. So Dr. Lynch discovered it and has been trying to replicate it, and he figured out how to replicate it. So now you can buy it through its Geislich product. It's the company who owns it. Geislich also does bone and a lot of other membranes and stuff. It's a big product company in the dental world, and they have the rights to Gem 21 is what they call it. It's the PDGF, platelet derived growth factors. Their competitor is Emdogain, which is Amelogens.
I've heard of that one.
Yes. And
Okay.
I don't think it works as well as Gem 21 personally.
Okay.
I know other people have their opinion. Like some people love Gem 21. I think their Gem 21 might be better for soft tissue, and PDGF is better for bone. So it just depends on the case. There's so much that goes into all the cases that we do, so much
Yeah.
treatment planning, what we're looking at, what materials we can use for grafting, what incision design we use. There is literally like 10,000 incision designs because everybody and their mother in perio wants their name on something. So
Yeah.
they make a
They just
mist,
create one.
a modified mist, a super modified mist,
Gosh.
a vista. I'm
Y'all
like,
already like to classify everything. Now everybody needs an incision type.
it's like I can't, and then I can't make this up. And I'm like, my attending's like, well, what design are you gonna do? And I'm like, I don't know.
I'm
Like,
gonna do
I know
Hannah's
what I want to
way.
do, but I don't know what it's called.
This one.
Yeah, I was like, this one.
Oh,
So there's a lot that goes into every single case that we do and every behind the scenes planning that we do for each particular case. So it's a lot more than people realize, particularly other specialties and GPs. They don't necessarily understand how planned driven this specialty is.
yeah. That's why I like this, like doing this, because I work in general. I mean, I see a high percentage of perio, but I still work in general. And hygiene school teaches you a ton of perio. I mean, the majority of our schooling is perio, but not to the depth of what periodontists do. And so I think kind of bridging that gap, not only for the public to understand both sides of this and the importance of this, but also for other dental professionals, because like you said, there's a ton of hygienists that drop in your life that ask constantly, when do we refer? What do you just flap like for your SRPs immediately, or do you, what are you doing? What is happening here? What should we be looking for of, we have this crazy vertical defect. You're saying Aussie. On our end, we're looking at it like you have this crazy vertical defect. Yeah.
Yeah. You're
So
like, "Cool,
I
we're
think,
gonna scale it."
yeah. So I'm like, it gives the the gap to the public between dental professionals and the public, but it also gives that gap between dental professionals and other dental professionals
For
because
sure.
every specialty is so different.
Yeah, and going back to what you were saying about the deep verticals, you can scale that. So if hygienists are listening, I want you to scale that because that granulation tissue has regeneration capabilities. It is the natural healing process of the body, granulation tissue. The reason it's not healing is technically called granulomatous tissue because of the chronic inflammation of the bacterial pathogens that are in it. This is why Linap and the laser treatment works so well, is because it's actually harnessing the body's capabilities of doing its own regeneration because we're not removing that tissue.
Right.
We're just killing the pathogens that are inhibiting the tissue from healing. So
Laser is
right?
crazy. It is crazy what laser could do and target because, like you say, it's not removing that tissue, but it
Mhm,
targets the bad from the good
mhm,
and helps you as your own body be able to do it itself.
right. Yeah.
Laser's come a long way.
Laser has come a long way. I mean, it's been around for a while, but it's become more prevalent recently. I would say in the last 15 years, it's become very prevalent and to the point where the hygienists are using diode lasers even for like bacterial disinfection,
Yep.
which
They
I
call it LBR, laser bacterial
laser
reduction.
reduction.
Yeah, it's where you're taking a diode. Now, I talked to someone about this the other day. You're taking the diode, but there's essentially a doctor setting and a hygiene setting. So it changes the setting of it to where the hygiene setting is supposed to not do anything like damaging, but on a molecular level, heat certain bacterias to reduce them or destroy them. But the LBR is they say it's on a molecular level. So they say that the tip of it, like if you put it to your hand, you wouldn't feel heat with the setting that they change it to, but that you do put it like subjectively activate. I just don't know what the particular setting is because I don't have a diode laser.
Right. You're not certified in lasers?
I have done like lecture CEs on it, but the school that I went to, like we had to do all of the lecture side, but our school didn't have a laser to actually give us the hands-on portion. So that is something I'm planning to hopefully do this year is do one way or another, do a hands-on just so I can see it and feel it and, like, actually see what it's doing. Because I think they have you do it, like most of the students I've seen in the last couple of years, they do it on, like, a hot dog, so you can, like, see it on the different settings. So I'm curious to, like, do a hands-on just to have an understanding of it, even if all I'm doing is referring people, but to be able to say, "Hey, this is the capability of lasers. Like I've seen some of this firsthand. Some of this is only with a specialist, but lasers really can add a lot to your treatment plan success."
For sure. And I think lasers are a great adjunct. Like I said, laser's not the magic wand that everyone wants it to be. Although I've seen some crazy results with it, but those cases, you do have to have special case selection for those cases. It's going to be really interesting to see where laser goes from here because there's a lot of great stuff out there and a lot of good uses. And I think in episodes to come, we can do a laser episode where we can kind of
Yeah.
get into the literature behind the different types of lasers, why we use them, because there's more than just the diode. There's a ton of lasers out there and they all have different uses. And so I think it's extremely important for providers, hygienists, GPs, anybody who wants to use a laser, you need to know what the laser's capabilities are. So stay tuned for new episodes coming up where we deep dive into all these surgical techniques, lasers. We're going to talk more about our diagnosing. We're going to get into classifications. This was kind of just a brief overview of what our philosophies are, kind of what we think about and what we're doing on our new patient evals. So just make sure you hit that follow and that subscribe if you want to keep along for this journey that we are doing here. And you can follow us on TikTok. I am Hannah DMD and Cheyenne RDH, and we will see you at the next one.
Peace out, Girl Scout.
Peace out. Love it.